Hi, welcome. This is the Breast Cancer Rehabilitation Wellness Summit for 2017. My name is Denise Stewart. I'm your host from Brisbane, Australia. This session is for women and their partners who want to know more about menopausal symptoms of the vagina. Some women are put into early menopause to reduce their estrogen or their body's estrogen. So usual methods of HRT intervention really can't be used to manage uncomfortable or painful vaginal symptoms. Today we have Dr. Anna online. Dr. Anna is a medical specialist in gynecology. Anna will present on the assessments and treatments for vaginal changes. Welcome, Anna.
So as Denise said, I'm actually a medical specialist in gynecology. So in Australia, we have a specialist qualification through the College of Obstetricians and Gynecologists, which is a 6-year training degree. I'm in private practice as a specialist gynecologist, and I graduated from the University of Queensland in 2000. You can see from my opening slide that I'm in the beautiful building of Wickham House, which is smack bang in the centre of Brisbane, Queensland, Australia. I first became interested in what's called Mona Lisa Touch, which is actually a brand name, but it's a treatment for a very important and distressing problem for women called vaginal atrophy. So this treatment is actually one of the first assisted laser treatments, which is what we call non-hormonal treatments, which is very important for some women who suffer certain medical conditions. And it's a treatment for what is called vaginal atrophy. I've now done over 1,000 treatments and found it to be very useful and very successful. So I'd like to share my experience with you, try and help some women who are suffering from these problems. As I've shown you, my practice is in the centre of Brisbane, and I see lots of women of all ages. I actually work at a hospital called the Wesley Hospital, which is one of the largest private hospitals in the Southern Hemisphere. So I'm going to talk to you about what is menopause associated specifically with the symptom of vaginal atrophy, ageing, and what affects quality of life. We're going to talk about the symptoms of vaginal atrophy and current treatment methods. I'm going to talk to you a little bit of science about the physiology of vaginal tissue, effects of the Mona Lisa laser treatment, and also, most importantly, the outcomes. This slide is a scientific slide, and this kind of encompasses what the problem is when you're looking at it in a scientific method. You can see here a little before and after picture. So this is actually a vaginal biopsy. So these slides actually came from Italy when they first started pioneering this treatment. And you can see that the slide on the left shows a very thin layer of skin. And pretty much to summarise the whole presentation in a nutshell, it's a before and after. And you can see very clearly on the after picture that darker purple skin layer, which was very thin, which is the cause of a lot of these symptoms, has become much thicker and much more comfortable. And I'm going to explain to you how this works and how we can achieve success in our patients. So we know that more than 95% of women reach menopause, and of course there's a life expectancy after that. So even when we're not talking about breast cancer patients, we're talking about women in general, it's a very common problem. And of course the genital tract is sensitive to a decline in hormones or estrogen, and then the clinical manifestation of this is a symptom called vaginal atrophy. And gradually that gets worse. It's not an instant thing. It gets worse 4 to 5 years after the menopause. When you can see with these little purple bar graphs, this prevalence then increases over time. So the range, perimenopause, 1 year, 2, 3, 4 years, an increasing number of women are suffering these symptoms. So vaginal atrophy will affect up to 40% of postmenopausal women, and it can affect their life. It affects sexual function and their quality of life. But unfortunately, and I've found this, I've been in practice since 2000, that only 25% of people seek medical assistance for this problem. These women with vaginal atrophy will suffer the symptoms of dryness, a medical condition called dyspareunia, which is a medical word for pain during intercourse, and that can be up to 38% of people. And also they'll suffer burning, discharge, and pain, amongst other symptoms. Vaginal atrophy can occur both as a consequence of a natural menopause, which happens gradually, and of course an induced menopause. And what we're talking about with an induced menopause is a result of surgical procedures where the uterus and both ovaries removed, and of course it can be an instant thing, or induced menopause as a result of cancer treatments, chemotherapy, and radiotherapy. And often it's more brutal and more instant when women have these aggressive treatments that they need to save their life. But unfortunately, it's put to the back burner because it's great. We've saved your life, we've fixed your cancer, but often these symptoms are often ignored by medical practice, and patients often just are too embarrassed to talk about it. So this slide on vaginal atrophy shows you nice little pictures. Now, what we're talking about is a decline in hormone levels. Just digress, we call it atrophy, but in fact, you will see something called the genitourinary syndrome of menopause. So the North American Menopause Society actually renamed it the genitourinary syndrome of menopause in 2011 in November in their joint meeting. Genito meaning vaginal and urinary, because some people have bladder symptoms as well. So we're going to be talking about vaginal atrophy and vaginal levels, but also people have bladder symptoms. So it's important to know that it encompasses all of these. So back to the slide, a decrease in estrogen will give you a reduction in the blood flow and those vaginal secretions, so it leaves dryness. You'll get changes or morphological changes, which is under the microscope changes in epithelium. And the epithelium is that skin layer that I was talking about. As a result of this, you'll get a decrease in what's called vaginal lactobacilli and an increase in vaginal pH. So the vagina is supposed to be acid, and these lactobacilli produce the acid. Less estrogen, less acid can contribute to these problems. So this bar graph again shows an increase in vaginal dryness after menopause. So a whopping nearly 50% of people 3 years after the menopause will have some form of vaginal atrophy. This slide looks the same as mine, a little before and after, but it's not. What we're showing in this slide is alteration in the skin. And again, you'll see on that left-hand slide that purple layer is very thin. And that's what it looks like after the menopause. It's atrophic, it's thin, and it's very sensitive. The picture on the right is a microscopic vaginal biopsy, not of after laser treatment, not after hormone treatment, but the healthy premenopausal vagina. That's what it's supposed to look like. It's very obvious, the difference. So what you'll see on that right-hand slide is that thicker layer. The thicker layer, you can see how those cells, instead of being a deep purple, they're quite white. And they're white because they've got lots of moisture. And there's actually a thing called glycogen, which produces the moisture. Beneath that layer, you can see the ridges in the lace. It's soft and stretchy and elastic. You see underneath that, lots of little red dots, and they're blood vessels. So you can see there's more collagen, more elastin, more moisture, and more blood vessel. And that's what it's supposed to look like. That's the healthy premenopausal. So the changes are quite dramatic. And you can see how that's going to cause the symptoms. The next slide then shows you a similar slide of a premenopausal healthy vagina. And you'll see actually not only those white cells on the top full of moisture, you'll see they're shedding. So it's active, it's biologically active, just like your cells turn over, your skin, your hair, your gut. The cells are supposed to be turning over. They're supposed to be healthy and active. You'll also see here that the glycogen will change the bacilli, make it acid, and make it healthy. So the glycogen exfoliated cells, so they're shedding off, will actually be used by that bacteria called lactobacilli. They produce something called lactic acid. They make the vagina acidic, and they actually prevent what are called pathogens. So pathogens are the bad things. The pathogens are the infections, the E. coli, the Klebsiella, common cause of things like urinary tract infections, which can become more common when the vaginal pH or environment, if you like, is not so healthy. So women may feel these symptoms. As doctors, we can see it, and it progresses over time. So sometimes it's a little bit dry, and then it becomes minimally dry, and 4 or 5 years down the track, very dry. The elasticity or the bounciness and moisture will, stretchiness, if you like, will change, and eventually becomes not so stretchy, painful intercourse, and then stenotic and dry and very difficult to have sexual intercourse and normal relations. As I've said, the vaginal pH will increase over time, i.e. less acid. Rugae means those little folds. So basically they stretch down and it becomes quite smooth and sore. Sometimes it goes pale and then it goes red and sore, and people even get like bleeding after intercourse. And sometimes we get things called petechiae, which is blood vessels, and that can also cause bleeding. So what can we do about this? Well, the idea of therapy is to actually change, not just to try and smooth things over, but actually change that tissue. So we want to restore the normal physiological condition of these tissues. And of course, who cares what they look like? It's how it feels like. We're women. So you want to regenerate these cells and make a disappearance of these uncomfortable vaginal symptoms such as the dryness, superficial, which is on entry, and deep, which is deep in your tummy pain. People don't want to bleed, they don't want yucky discharge, and they don't want to feel inflamed. So systemic hormone replacement therapy has been the gold standard for as long as I've been in practice. So 10 to 25% of women who will use HRT sometimes get symptoms, but generally it works. Although we've had issues in years, particularly in Australia, where we've had a medication called Vagifem, which was 25 micrograms of estrogen. It dropped to Vagifem low, which is a lower dose hormone, because there's concerns about absorption of those hormones in some women. And I find that the lesser dose doesn't give them such good treatment. Of course, there's hormone replacement therapy, which is fantastic if you can take it. But some women have other medical conditions, including cancer, but also deep venous thrombosis history, where they get clots in the leg veins, smokers, diabetic, the list goes on and on. So not every woman, I should say, is actually suitable for hormone replacement therapy. So that's where we look into what we call non-hormonal therapies. So the idea of lubrication is just trying to make it a bit more comfortable as much as you can. But some women either want to avoid hormones or have a history of hormone-sensitive cancer and are not able to take hormone because it increases their risk of recurrence of their cancer. So the vaginal estrogen therapy is more effective than the systemic, which is a blood, in your swallow the tablet, goes into your blood, hormone therapy. But of course, also this treatment is limited to whether you can take it or not. And of course, it's limited to the treatment period, i.e., as soon as you stop it, the symptoms will return. In my practice, I find patients find it doesn't always work and they get sick of taking it. So with breast cancer patients, vaginal hormone therapy is a real problem because vaginal atrophy can result from treatment with cancers, and a lot of these tumours are hormone sensitive. So there's limited effectiveness in the non-hormonal treatments. To summarise the existing treatments, the local hormone therapy is the most effective. Lubrication, rehydration is almost palliative, like a bit of grease and oil change, but it's still going to be sore because the tissue is still going to look as I showed you on those slides. And therapy needs to be used over a long period of time. It depends on compliance, and it is not recommended for women with hormone-sensitive cancers, and some people just don't want this treatment. So now we're moving on to the Mona Lisa touch, which is the world first in the non-hormonal treatment of vaginal atrophy. So how did this come about? Well, it actually isn't new technology. It's a very old technology, and it's come from dermatology. So skin specialists have known for years that there are different wavelengths of energy sources, and for over 25, 30 years, they've been using what's called fractional CO2 laser for facial skin. They're using it for rosacea, scar revision, even cosmetics. So in Italy, in 2008, Deca Lasers actually began looking at vaginal lasers, and they were looking specifically at the Mona Lisa touch. And it was one of those moments where a gynecologist in San Raffaele Hospital in Milan probably had a nice espresso or skinny flat white or whatever they have in Italy and Milan on a Friday morning, and said, hang on a minute, why could we not use this for our women? Because it's heavily absorbed by water, these particular wavelengths. There's a moisture content in the vagina, and that's how this actually came about. So what happens with the treatment? So there's action on the tissue. It's a very easy treatment to undergo. There's little dots of laser energy, approximately 0.2 millimeters wide, evenly spaced over the tissue. So a little probe is put in, and we put a little bit of topical anesthetic, which is just a bit of cream. Pop that little probe in, so it's very easy to put in. Even in my patients who have terrible trouble with intercourse, I can almost always, without exception, do that first treatment with almost no pain. Just a little bit of pressure, because it's not like a pap test. We've got to open it up and take some cells. It's thicker than a pencil, but a little tiny little probe that gets put inside. When the laser's activated, these tiny little dots are spaced over the whole tissue, and only 7% of the surface area is treated. So you've got untouched tissue in between, so it heals really quickly. It specifically targets the water in the tissue to deposit heat. Now, this energy source is what we call a long wavelength. It's a laser pulse that makes a tiny little dot in the skin. The dots heal very quickly. The dots go 0.5 mil beneath the skin. It goes nowhere else in your body. So everybody asks me, what's going on here? And it's a local reaction where you get these heat shock proteins, which triggers this cascade to waken up the cells again. This particular wavelength is heavily absorbed by water, so there's almost no risk. The treatment is local, it's nowhere else in your body. So how I explain it to patients is energy sources. There's so many energy sources in the universe. Short wavelength is the dangerous energy source. So a CAT scan or an X-ray or even a mammogram is short wavelength. This is what we call long wavelength. It's just in the tissue, nowhere else in your body. So basically, putting little dots in the skin, goes nowhere else in your body. And I explain to my patients there's really only two risks. Number one is eye damage. I said, if I accidentally shine in your eye, I can cause eye damage. I'm certainly not that much of a bad shot. But by law, we have to put little safety goggles on everybody who has this treatment. That's number one. And number two, if somebody has herpes infections, like genital herpes or cold sores down there, they can be carrying virus. You're putting little dots in the skin and you're prone to this virus. Those patients are covered with Valtrex or an antiviral medication so they don't get an outbreak. So it's not really a complication. Someone has to have the virus to start with, and they know that from dermatology. So if people are having laser on the face and they get little cold sores, the dermatologists cover with that laser treatment with antivirals. We do exactly the same with the Mona Lisa treatment. So it's not really a complication. I've never had that complication because we ask that history. So it's tiny little dots in the skin, doesn't take very long to do, and that's pretty much it. So moving on to the next slide, this is a very much magnified picture of these hundreds of tiny little dots. And you can see these dots are very tiny. If you get your ruler out, have a look at 1 millimetre. We're looking at 1/5 of 1 millimetre for each of these dots. So they're tiny little dots, and you can hardly even see them with the naked eye. Under the microscope, this is what it looks like. So you can see how there's this tiny little crater, and that's where that little energy goes just beneath the skin to get in there, deposit that energy source to get things moving and get things activated again. So the effects of Mona Lisa touch, I have to go scientific, so I hope there's some scientists amongst the audience, but basically to explain, we have tissue called fibroblasts. These fibroblasts are activated in the synthesis of both proteins, mainly collagen, and the molecular components of what's called the ground matrix, which is the building blocks. So the mechanism of the effect is due to the specific thermal effect from the CO2 fractional laser used. So they have a special emission technology called the DECA pulse or D-pulse that delivers the energy to this tissue. And the benefit of the DECA pulse, because there are actually other brands of lasers out there, very well marketed as well for treatment of vaginal laser, is that DECA Laser Factory, which is outside of Florence in Italy, has actually scientifically developed a technique where the laser pulse gives you a quick burst of energy and drops off really quickly. So it basically gets to right where you want to be and disappears quickly. And the point of that is you don't get any thermal spread. You don't get any damage laterally, which is sideways. So you're just treating that dot. Some cheaper lasers that are made, I've certainly seen in South America, one of the presenters who had seen some lasers that have come out of some factories in China, where if you're not going for the best technology, it's causing damage. And so you don't want those lasers. You want the actual treatment that'll give you the energy that you want, the drop off of energy very quickly. So therefore you're not getting any harm as a result. So these treatments then activate these proteins, which basically promotes fibroblasts, which make collagen and elastin, which is what we're trying to promote. So fibroblasts, under the microscope, has a dual role. They're the building blocks, they produce your collagen and elastin, and also the glue, which is the moisture, if you like. So hyaluronic acid and proteoglycans, etc. Under the microscope, i.e. histology, it restores the correct composition. You want it to get back to what it looks like before the menopause. The collagen fibers are inside that ground substance with a lot of water, and enables transfer of nutrients like moisture and water and makes things healthy and comfortable and how they used to be. So this is actually what the Mona Lisa looks like. So postmenopausal women actually went through studies back in Italy when they started doing this treatment, and they found, unsurprisingly, that it's been fantastic. So the practical effects is you get more nutrients, the thinner tissue becomes thicker, and you've got more active cells. Dryness, there's a little picture of a poor old dry, cracked bit of pavement there, and my patients saying to me, oh, it feels like razor blades, it feels like sandpaper sex. These are the words that I hear time and time again. So you've got more blood vessels, more comfort, more collagen, more moisture, and it's helping them. Let's not talk science, let's talk about itching, burning. And so some patients have this treatment who are not sexually active, but they can't even walk and they feel uncomfortable. A lady that had a property in Western Queensland, if anyone's aware of Western Queensland, she couldn't get out to the paddocks on a tractor because it was just so uncomfortable and dry. Let's forget about intercourse. There's all these other day-to-day things where we want to commence moisture and comfort, just being able to get on with life as per normal. Of course, this cute little picture is the obvious, so sexual intercourse. You've got a transitate, which is fluid that comes from blood outflow, and if that slows down, you're going to have decreased moisture. But for sexual arousal, we need more blood flow to the vagina, and we rapidly need to increase that to make things more comfortable for women. Again, back to the slide on pH changes, you want more acid. So in reproductive age, you want more acid. After the menopause, that decreases. So let's have a look at the published clinical trials, how this actually works. So the first trial came from Milan, and they found that they got really good result, and they got good long-term result. And a lot of their initial patients in these trials actually were breast cancer patients. You can see the slide. Back to my, how did this all start? A little before and after. So this is actually the same scale. So the slide on the left versus the right is the same patient, same magnification. And these are the actual results that came actually from Italy. They were kind enough to share them with me. So you can see very clearly the same patient, same vagina, biopsy, different person almost. You can see the cells are healthier, the epithelial layer is thicker, and they're more comfortable. So to summarise, the mucosa is well nourished. There's more papillae, which are those little ridges. The glycogen, which is the water content, so the white bits in the cells is clearly present. And after the laser treatment, there's more collagen and ground fibres and more elasticity. This is yet another slide. So different curves. Again, you can see very clearly the thickness. So you can see those little black arrows, thin epithelium, thick epithelium. You can see there's more water there, more blood vessels, which are those little red dots underneath. And you can see those little ridgy things, which is called dermal papillae, which makes it more elastic and expanding as well. Another patient, again, you can see in this slide, thinner, thicker, but this little dotted line shows you that circle where the cells are actually shedding. So you can see they're not just sitting there inactive, they're more biologically active and more turnover and more moisture, more pH, more lactobacilli, because there's cells for the bacteria to feed on, make the vagina more acid. So they looked at these, and they didn't just look at histology, they looked at clinical effects, and there are lots of different ways we can look at. There's a female sexual function index. In Australia, we have a different index that we use looking at sexual functions. There's lots of different modalities that you can actually objectify changes. And they found there was a significant improvement in laxity, dryness, irritation, and dyspareunia. So this first research led on to more research. And as we speak now, there are over 20 or more published peer-reviewed research papers from multiple centres around Europe, USA and Australia, and they all show the same thing. They all confirm similar findings. Now, if you look at those trials, we'll be getting satisfaction rates in the order of 84%, 88%, 92%, 95%. And I can tell you in my nearly 1,500 treatments that I perform now, I'm finding 90 to 95% satisfaction in all of these symptoms. So it does improve itching, burning, dryness, lubrication, pH, laxity, some mild incontinence symptoms, and pain with intercourse. And early research, as I said, we're talking about women who'd not responded to estrogen. And it was found in a lot of these studies it worked in women who were just postmenopausal, but also breast cancer patients. In fact, there's a lot of good data coming out, and there's some of these trials of those 20 are specifically about breast cancer patients as well. Now, sometimes people say, what about that other 5%? It's important as a medical practitioner to take a proper history, examine the patient. I always make sure there's nothing else going on. We always exclude other things like candidiasis, thrush, dermatitis. There's a condition called BIN, which is precancer vulval cells. So there are other things. We don't just launch into this treatment. It's important that if you are looking at this treatment, that you see a gynecologist and you have a full medical clinical assessment. In addition to that, there's a psychosexual element, and I've not spoken about this in this talk because we're talking about the laser. But there's always this thing that people have to realize that, they've had pain, they remember pain, their body remembers pain. It's important to look at relationship issues, look at the psychosexual side of things as well. The other thing in those very few percent of people who feel like they're not responding, it's often they're not responding to this laser treatment, but there can be other things going on. We have a very good lot of pelvic floor physiotherapists in our city, and I work very closely with my colleagues from the physiotherapy departments. And we talk about there's a condition called vaginismus, which is a vaginal muscle tightening. So people go, oh, it's been so sore to have intercourse. They pull up their legs and they pull up their muscles, and the physiotherapist can help with that. So we can help the dryness, but sometimes it's important to realise it can be other issues. And I can say that if we're putting it all together, looking at the laser treatment, but looking at the psychosexual outlook, looking at the physiotherapy and the muscle outlook, we can get a really good response in almost everybody. So with the laser, you can see it's fairly dramatic. You can see at baseline, which is these little graphs, is the blue line, and you can see after 1, 2, or 3 sessions. So in summary, it's an outpatient treatment, and people generally have 3 treatments. We time them every 4 to 6 weeks apart. So you can see the blue is baseline. I have these symptoms, and this is after 1, 2, or 3 treatments. So it is a progressive change and a progressive improvement in symptoms. So sometimes after 1 treatment, the patients will say, oh, I just feel a little less uncomfortable, but not that great. After the second, oh, gee, that second treatment was good. And I explain this to the patients, that it does build upon itself. So it's not an instant cure, because when you think about it, we're actually physically changing that skin. So it's not instant before and after, it's a gradual improvement in symptoms. So most patients have 3 treatments. Most people have 1 top-up at 12 months. And there was a fantastic study that was published in the United States in October of 2016, where they looked at the longevity of this treatment, and they looked at outcomes at 12 months. And that benefit was maintained at 12 months. So the standard around the world is to have 3 treatments and then just 1 top-up once a year as a maintenance. So you get that long-term benefit as well. And of course, the longest trials in this in gynecology has been dating right back to 2008 from Italy. So you can see there's a very dramatic change and long-lasting as well, which is what people are looking for. I briefly touched upon urinary symptoms, and you can see the word dysuria. So these graphs are before and after the Mona Lisa, which is painful urination. Urinary urgency is that, oh, got to go to the toilet, key in the door, or oh, get to the car keys, or had a cup of coffee and up 3 times at night. Urgency incontinence is where you actually leak when that happens. And stress urinary incontinence is when you're coughing and sneezing and urine is let down. So for mild urinary incontinence, and certainly the urgency incontinence, the vaginal wall supports the bladder, the blood vessel improves, the pH changes so you've got less bacteria, and we get a great improvement. Naturally, if somebody's had 3 10-pound babies born vaginally, if the pelvic muscles are not supporting the bladder, this is only going to be a mild improvement because that's a muscle change, and that's where the pelvic floor physiotherapists come in as an adjunct to this treatment. And of course, in severe prolapse or severe what we call urinary stress incontinence, stress being coughing, sneezing, jumping on the trampoline and the urine's coming away, that's surgery. So that's my Mona Lisa, and this is the room that we're standing in as we speak. Curtain behind me is the laser device, and you can see how it's just done in the office. Come in, have a chat, and we can treat. So when you come and see me, I do assessment. As I said, we make sure there's nothing else going on. We check that the pap smears are up to date and there's no other diseases. And, my consent form has changed over time. When I first started doing the treatment, and I've been doing this treatment for over 2 years now, I spoke to it. Now I've kind of developed my own little consent form, talking more about how the treatment has changed over time, but also how it's important to look at psychosexual aspects as well. But basically, what was the spiel, if you like, when I started doing this 2 years ago, has started and remained exactly the same, because it's exactly as we've always expected it to be. Fantastic result. So, outpatient treatment. Some people come and chat to me and they just get up there and we treat straight away. I'll give them a magazine to read while they're sitting there. Some people come, have a think about it and come back. It's painless. You don't feel nothing because I put some cream on and I put a little probe in. But when we actually treat, when I activate the laser, people don't feel the laser. I press the foot pedal, there's a little gush of air, and people describe it as a little vibration or a little puffing sort of sensation. When I start, I'll count you in. I'll say 1, 2, 3, go. I press the foot pedal, you feel a little buzzing sensation. And they go, oh, that's it. And then the actual treatment takes about 5 minutes to do. I often treat the skin at the opening of the vagina because some people get a thing called entry dyspareunia, which is just coming into the vaginal wall just on the skin, and it helps to treat that area as well. So obviously we check that there's no herpes at that time. We check there's no active infections like thrush at that time. As you can see from my pictures, that my office is right middle of the Brisbane city, so my patients will jump on the train and go back home, or walk down into the city, go back to work, or go and have lunch with their friends. There is no downtime whatsoever. Some people get a little bit of vaginal spotting just from putting a little probe in. If they're very, very sensitive, I'll give them a little panty liner only that they might need from time to time. That's the actual laser device, so that's the screen. So you can see how it's quite scientifically set up such that we can actually organise the treatment such that it is individualised to each person. So there are a lot of physics and there's a lot of science behind exactly how much energy. And you'll see in the bottom that emission mode DP decapulse, and that's where this particular device has got it over the competitors in that we're getting exactly what you want, how you need it, with no side effects and no other damage. So how it works, the probe's put in, it is tiny little dots into the vaginal walls, as you can see there. So these are some of the earliest studies. So this is pilot studies in a journal called Climacteric. The next is another study from Italy where they concluded, this is from their original data, that the microscopic changes occurred after one single treatment and restored those changes and helped sexual function and quality of life scores. Another one, lasers in medicine, scientific journal looking at fractional laser treatment. Another one, looking at sexual function in Climacteric. There's ongoing research. So they did a long-term study in breast cancer survivors in Europe. The August 2016 looked at actually the pH. The USA study was looking at the improvement at 12 months being maintained at 12 months. My study, the Wesley Medical Research Institute at the hospital that I work at, has recently approved a study where I'm going to be doing histologically biopsies of women having this treatment. Instead of after 2 treatments, I'm going to be looking at women after 1 or 2 or 3 treatments to actually look microscopically how those cells have changed. I've organised to have a histopathologist, which is a pathologist, actually to have a look at the slides, and we're going to look at not just collagen elastin, not just the thickness of the skin, but which collagen, which elastin. We're going to count the blood vessels, or he's going to count the blood vessels. I'm going to take the biopsies and correlate that to a degree in improvement over time, just to further expand the world knowledge of this very important treatment. So as I said, 84% success. Women are getting improved quality of life at 12 to 24 months. A study was published by an Adelaide doctor who showed that at 24 months, again, not just 12, but 24 months, these treatments were maintained. 3 treatments initially for optimal results, and then just 1 treatment every 12 months, I say, rather than 24 months to maintain. So you only have to have 1 top-up a year rather than go right back to how things were previously. None of my patients want to go back to how things previously were. People want to have quality of life. Regards my breast cancer patients, I've treated a lot of women through that I've met through what we call the Choices program, which is a sort of self-help, holistic program in our city. And a lot of the patients have said to me, look, I had my cancer treatment, things were supposed to be good, but, I'm young, I'm married, and people have really not dealt with down there. So the idea of this treatment is to deal with what's down there and improve the quality of life. So I hope that this has been of interest to you. Get on the Mona Lisa Touch website, get on my website. There's heaps of information there. And thank you for listening.
So what I love, Anna, is that you've given people a really clear vision of what a non-hormonal treatment is like, and that the idea of the summit is that people get information, because as you also experience, is that people tend not to get this in their early phase of treatment, and so the information either may not get to them or it may be a bit delayed in getting to them. So thank you very much, Dr. Anna, for that. If people are looking to take up this option or have a chat with their doctor, do they go to their GP? Can you just help people work out what their next step would be if they thought that this might suit them?
So if you're interested in this treatment, the first thing you need to do is have a think about it, understand what it's about, have a look at my presentation, jump on the web. There's lots of stuff there on lots of different sources. You're probably better off Googling Mona Lisa Touch, because then you'll get our information. And in fact, if you're interested in having the treatment, you'll see in a lot of places, including in Australia and New Zealand, they have a Find a Clinic. In overseas sites, they have exactly the same thing, Find a Clinic. And you literally just pop your postcode in and there it is. So when the patients come to see me in this country, we have a referral basis system where patients see their general practitioner and get a referral to see the specialist for the treatment. Because a treatment's private treatment, we don't insist on a referral because we don't want to put people off. So I'm very happy to see unreferred patients for this treatment if that's what they choose to do, because we don't want to put the barriers up. It's good if you can chat to your own family doctor because they've got that holistic approach looking at all of you. But some of my patients can be referred from their own family doctors. A lot of the patients who have cancer are referred to me by their medical oncologists. Some of the patients are referred by their breast surgeons or their gynecologic surgical oncologists. So it's not imperative that you have a referral, but you've just got to do what's most comfortable for yourself. But I will see patients without referral and, assess the suitability for the treatment and look for other issues that may be able to help them. But you've got to do what feels right for you. And it's not the same recipe and it's not the same picture for everybody. But certainly every doctor is happy to deal with this problem if they have a specialist interest in this problem, which will include the family doctors, but also the specialists involved in your care.